Day one of pathophysiology. Today we're going to be covering just genetics and genetic disorders. We're actually really going to start really easy. We're going to start with some definitions and just lay down some fundamentals of the field of pathophysiology. So real pathophysiology is really pretty complicated. Everything really impacts everything else. We're not really going to learn it this way with the crazy arrows. I just want you to be aware that everything is going to interact with everything else. We're going to kind of simplify it, but as you move forward in this program, you're going to learn how everything is really interactive and everything's going to impact everything else. So some of these are really, really self-explanatory. Some of these definitions I think are really simple. You guys know about clinical manifestations at this point, right? It's about the signs and the symptoms that pop up in response to an illness, to a pathophysiological process. What we're going to be talking about in pathophysiology is how those clinical manifestations are a direct result of the pathophysiology. It's the cellular processes that cause the signs and symptoms. Our cause and effect is going to be really important for you to understand so that you're not treating signs and symptoms, you're just treating a disease process, right? You're dealing with a disease process. So the vocab word etiology is about the cause or causes of a particular disease process. It's not just one thing, it's multifactorial. For example, most disease processes require what we call a vulnerable host. We need a person to be vulnerable in the first place in order for a disease to take hold. Usually there's going to be like an environmental stressor, for example. This is an example for a mood disorder where a person is vulnerable and then a stress is going to overcome any protective factors, and then they're going to probably have a biological underpinning to that mood disorder. There's probably going to be social factors in their mood disorder. So it's very complex and intermingled. Obviously, some diseases, there's a bacteria and it's more powerful than anything, and there's nothing you can do about that, right? Even if you have a very strong immune system, C. diff, let's say, is going to be able to overtake you, just as an example, reach in for something random. So etiology is a complex notion. Lots of factors come into play. Some basic etiologies that are kind of outliers. Idiopathic is a big one. Idiopathic just means we have no idea. Science is pretty amazing. It's great what we have figured out, but there's still a lot that we have not figured out. So every once in a while we'll run across an idiopathic disease process, and that just means we don't know what's causing it. We've identified there is a disease process. We may have given it a name. It's probably a syndrome of some kind, but we don't know the cause. Another etiology that's going to pop up every once in a while is iatrogenic etiology, and I actually don't like your book's definition of iatrogenic. An iatrogenic disease is something that healthcare caused it. We went in and performed a surgery, and that surgery led to a disease state. Now, your textbook wants to tell you it's unintended or unwanted, and that's the part that I disagree with, because sometimes we go in and we perform a procedure knowing it's going to lead to a different disease state, but the new disease state we've decided is preferable to the disease state. So, for example, if somebody has a thyroid tumor, maybe they've got hyperthyroidism, we may remove all or part of their thyroid gland, and then they have hypothyroidism. That hypothyroidism is iatrogenic. We caused it. It doesn't mean that that was an unwanted or unintended procedure. We did it on purpose because there was a tumor, right? And the hypothyroidism is more manageable than the hyperthyroidism or the tumor or whatever was going on with that thing. So I think it's on your worksheet today. I would just not include the unintended or unwanted part in that definition. I would just say caused by medical treatment. We did it. Sometimes we give people drugs that cause nausea. That's iatrogenic. We did it on purpose, though, because that drug was necessary for that person. And then again, if a surgeon went in and nicked an artery on the way into the liver, for example, that would be iatrogenic too. That would be an unintended or unwanted. It could go either way, though, in my opinion. So pathogenesis. A lot of these things are similar, right? Etiology, pathophysiology, we're all talking about how diseases come to be. So pay attention to the small differences between these things. Pathogenesis is the mechanism where the stimulus leads to clinical manifestation. So the beginning of the disease, how did it happen? When you understand these things, when you understand the pathophysiology, the etiology, the pathogenesis, that's actually going to decide your treatment plan. We decide treatments based on the underlying process. So just an example, we're not doing shock today. Shock's a week or two down the line, but we will ultimately learn that there's different kinds of shock. There's hypovolemic shock where you have really low blood volume. There's cardiogenic shock where your heart is not pumping blood, right? If you have hypovolemic shock because you got stabbed, then replacing your blood volume makes a lot of sense, right? Because that's the problem, is you don't have the fluid moving around your body anymore. Whereas in cardiogenic shock, the fluid's there, it's just not moving. So putting IV fluids into that person may be a little bit less useful in that case, versus our treatment plan is probably going to be more about, can we get the heart beating properly again? Can we get it to beat a little bit more strongly? So we're going to use other techniques depending on the underlying treatment. You can't just say it's shock, so we do X. You have to understand the pathogenesis, the etiology, the pathophysiology. And stop me at any point if you have questions. Are there questions so far? All of our pathophysiology is based on the concept of normal. We start with a normal person and then some parameter becomes abnormal. But we have to understand statistically what that means, and you guys don't really get statistics officially until like quarter 11 or something ridiculous like that. So let's just briefly touch on what it means to be normal. What it means to be normal is to be statistically normal, and it's influenced by a lot of factors, including social norms, right? Age, all kinds of things. So this is a standard regression curve. It means that most of the population is here. It's like, imagine this is test scores. And let's say the class average was a 70, which is pretty standard for my first exam here. So class average was a 70, most people got a 70, most people got between a 65 and a 75, right? So that's why it's really high right there. And that means that there's a sort of standard deviation, is what this means, of 5 points. So you can apply the standard curve to almost anything. Heart rate, what's a normal range for heart rate? 60 to 100, you said? So this would be 60, this would be 100, this would be 80 right there, right? Is what we would anticipate this looking for. So if somebody's at 40, that may be cause for concern. If somebody's at 110, that may be cause for concern. Is there ever a situation in which 40 is not a cause for concern? What is that situation? They're a marathon runner. They're extremely physically fit. Absolutely. So normal doesn't always work for individual situations, right? And some other factors that influence that are cultural, gender, biological sex, socioeconomic status. So in this culture, neck pain may be incredibly normal, right? But in our culture, neck pain is a sign of some kind of pathology. Age is going to change normal. So the ECG changes with age, right? All kinds of factors change with age. Response to drugs changes with age. Vascularization changes with age. And that's going to influence your understanding of normality, your interpretation of lab results, your understanding of pathophysiology. We're still just working on vocab at this point. This is the easy stuff. Epidemiology is the study of the distribution of disease, the patterns of disease involving aggregates of people. So we're staying in a population now. Occurrence, incidence, prevalence, transmission, and distribution. And we will go through all of those vocab words too. We're just establishing vocabulary. So incidence and prevalence, again, are parts of epidemiology. And this is really a pretty simple concept. What we're saying here is an incidence is new cases. I'm really bad with remembering real numbers, but let's say that 50,000 people contracted HIV this year in some geographical area. I don't know which one, but that probably happened. 50,000 new cases. That's incidence rate. However, there's also the concept of prevalence. People who contracted HIV before, for the most part, still have HIV. We've only cured 2 people with like incredibly invasive procedures that are very, very difficult. So prevalence is going to be all of the new cases, including all of the old cases, pre-existing. So 1 million people living with HIV as of this year, or whatever the real number is. It's not 1 million. Make sense? Good, good. Okay. There's a problem with this chart, or this image, and as I'm talking about it, see if you can spot what the problem is, because then I know you're paying attention. So the demics are just distributions of disease. Another concept for epidemiology is how that disease is distributed geographically. And in general, there are going to be geographical barriers to disease spread. Now, we live in a modern age with airplanes and things like that, and that's absolutely influenced the spread of disease, right? We used to have, if there's a big valley, if there's a big river, if there's an ocean or a sea, then we're going to actually contain a disease that way, right? We don't really have that quite as well as we used to. So an endemic disease means there's some incidence rate in a population that's just normal. Let's say you live in rural Brazil, and your community every once in a while experiences some cholera. Somebody gets cholera every once in a while. That's just a thing that happens there. That would be an endemic disease. And the local, healthcare situation is such that they can't quite eradicate it, but they can treat the cases that they get to an extent, right? That would be endemic. And it's just in this rural town in Brazil. It's not spreading to, let's say, Ipanema or anything like that. It's just in this one area. An epidemic disease means maybe it started as endemic, but it's spreading. It's spreading to many people in the same time in the same area, right? We had our incidence rate of like 3 people get cholera every year. Suddenly the whole population's is exposed to cholera. Not everybody's going to get cholera who's exposed to cholera, but whatever. That would be an epidemic situation, but we still haven't crossed geographical boundaries yet until we get to a pandemic disease. So here's our epidemic. We spread to a wide area. And then a pandemic means we've crossed geographical barriers. We've gone northern latitudes, southern latitudes. We're crawling higher and higher up or lower and lower down, whichever way. So let's think about like Zika virus, for example. Zika used to be an epidemic, right? It was confined geographically, but it was a serious situation even then. Now with climate change, we have warmer and warmer temperatures to the north. We have mosquitoes encroaching farther and farther north. And now we're starting to have a pandemic on our hands. Okay, so tell me what the problem is with this chart and the way that it represents one of these diseases. And yeah, it's showing a pandemic. Right, like, okay, there's cholera up in Alaska too, or whatever it is. Yeah, these should all be different colors if we're going to draw this well. So you guys did awesome on that. I know you're paying attention. Good job. I'm happy with it. All right, any questions so far? Moving on to levels of prevention. That was epidemiology. Levels of prevention. What we do with medicine is we prevent. A lot of people say, oh, Big Pharma is only interested in treating the disease. They don't care about you before you're sick. And maybe, but there's also a lot of levels of prevention that we can enact to prevent disease in the first place. And then when disease is established, prevent it from getting worse. Prevent it for causing sequela, which is another word we're going to have coming up here. So primary levels of prevention. These are broad scale things. These are community-wide efforts. If we improve nutrition, if we improve the economy, if we improve housing and sanitation, If we educate a populace about sanitation or nutrition, if we can get them healthier food, that's actually going to have a massive impact on not just quality of life, but health. That's actually the biggest way we can improve health outcomes for everybody. It's actually much more effective than what a lot of you will be doing in terms of, like, treating a heart attack or treating obesity or treating some other problem. That primary level of prevention is probably the most effective thing that we could do. And of course, it's the thing we do the least of, right? Secondary level of prevention means routines. The yearly physical exam, the routine pap smear. We don't think anything is wrong yet, but we're going to check to make sure. And that means we can prevent things very, very early from getting worse. We can prevent things from getting worse very, very early when we do routine things, secondary level of prevention. Some people have asked, would I put vaccinations under primary or secondary? And I would argue, are you getting your vaccine as a matter of course, or are you going to a public health event and where everybody's getting vaccinated? If there's a public health event where everybody gets a vaccination who comes in the door, I would argue that's a primary level of prevention. Excellent. What's up? It's a good question. Probably secondary since it's routine. It's a good argument, a baby getting a vaccination as a matter of routine, but on an individual level. I'll call it secondary, but my word is not law on this. I didn't invent it. It's a good gray area. Yeah, the flu vaccine at work is an excellent example of a gray area for that. So, tertiary level of prevention means a medical or surgical intervention after disease has become established, and that's really just as important. So say somebody has type 2 diabetes. We've discovered that they have type 2 diabetes. They need treatment, right? If they don't get treatment, their disease state will worsen. They could lose a foot. They could lose their vision, right? Diabetic retinopathy is a major issue there. So our interventions that we put in place for that person, that would be considered a tertiary level of prevention because we're preventing amputation. We're preventing blindness as a result of that type 2 diabetes. And then quaternary prevention, this used to not be on the slides, but I added it. Preventing too much medical intervention. So somebody gets on a pill for condition number 1, that pill causes condition number 2, we give them a pill for that, then we give them a pill for the side effects of that, and then the side effects of that. We want to do the least invasive form of treatment that's going to give them the best quality of life. It is possible to damage somebody's liver by giving them too many meds or give them accidentally end up with medications that interact with each other badly. Or what if they don't actually need surgery? Some people will say, I really want back surgery for my back pain, but it may not be indicated for that person. So preventing too much medical intervention. It's pretty simple. Any questions? Some cleanup vocab. Most of these you should be very familiar with. Risk factors. If somebody's a smoker, if somebody is morbidly obese, those would be considered risk factors. You guys know symptoms and signs. You guys know syndromes? How are you on syndromes? Actually, let's cover syndromes anyway. A syndrome typically means we don't know what it is yet. We have diagnostic criteria for a condition. For example, fibromyalgia syndrome. We know there's something called fibromyalgia. We actually only recently started believing women about fibromyalgia, that it's a thing that's diagnosable. We've got a collection of signs and symptoms that is recognizable and diagnosable, but we do not understand the underlying disease process of it, so we call it a syndrome, typically. One reason I want to bring this up is that sometimes, every once in a while, we're going to see a disease state that is labeled a syndrome, but since the discovery of that disease, we have figured out its pathogenesis, and we're just going to be like, why is that still called a syndrome? Because we forgot to change the name. That's all. Yeah.
So like with my daughter's heterotoxicity, that would be because they're still kind of learning.
Right, they're still kind of learning, but Yeah. Yeah.
What about like Cushing's?
Cushing's is disease. Yeah, we understand the physiology of that one. If somebody's calling it, well, let me get back to you on that because there's a couple of ways that you can have like a Cushing's scenario. It's going to be an overabundance of adrenocorticotropic, or not adrenal gland hormones. A couple of different things can cause that. So there's Cushing's disease, and I think Cushing's syndrome may be something different that is associated with a different pathogenesis of it. It's a good question. Okay, more cleanup. Latent period means we don't always get a disease state immediately after the onset of the pathogenesis of the disease state. A prodromal period is when the first signs and symptoms appear. Some things will have a latent period. You'll be sick, then you'll be fine, then you'll be sick again. Exacerbation means it's getting worse. Remission means it's getting better. It may mean the disease is cured, or it may not. So really frequent use of the word remission is cancer is in remission. We will not know if that person has any cancerous cells or not left in their body for a very long time, potentially. Convalescence is the stage of recovery. I'm in convalescence from my wisdom tooth surgery right now. And then sequela is going to be a big one. Just that root word is sequel, right? And I've already used this a couple of times. So a sequela of type 2 diabetes may be gangrene of the foot, right? Or diabetic retinopathy. It means a disease process happened and then another disease process happened as a result of that. And we're going to see a lot of sequela. We're going to see a lot of main or primary physiological process that leads to a secondary physiological process. One thing we're going to learn about pathophysiology is that a lot of our disease states, some of it's going to be direct. You get a bacteria and it destroys your intestinal epithelium. But a lot of the problems that our bodies have dealing with disease are caused by our body's response to that disease. We're going to spend a lot of time very soon, not today, on infectious and inflammatory. The inflammation response is going to be particularly interesting to you in terms of understanding disease processes. So yeah, there's the bacteria invading your GI tract, but there's also your inflammatory response to that. And sometimes it's your response to it that kills you. And that's what we're going to be discussing. So we'll start with this idea of homeostasis. This should be review. You have your set points in your body. You have your set respiratory rate at rest. You have your set blood pressure. You have your set body temperature. And they'll waver within a small area, but hopefully they don't get too out of whack, right? So if they do start to get out of whack, if your body temperature is too high, you'll have a receptor to detect that elevated temperature. You will send that information to a control center, probably your brain. Your brain will send out via an effector a response to that stimuli, like to your sweat glands, and then you will sweat, and that should help cool you down and return you to homeostasis. All review? Good. Now the next concept, the next level up for this is allostasis. It's pretty similar to homeostasis. It's still, we're going to try to return to our set point, but we're going to do that in extremes. The next few concepts are all going to tie into this. How does our body respond to extremes? So the examples I gave you here are, how do you maintain body temperature if you're in the Arctic tundra? What if there's a hypothermia situation? Or what if you live there? What if you are next to an active volcano and there's a hyperthermia situation? Are you going to be able to adapt to that? I think probably a better example for allostasis is going to be like pregnancy, right? Your body's at these new extremes. You have a new blood volume. You have a new body temperature. Everything's at a different set point now, right? So what we're saying is that allostasis is homeostasis in a stressed environment. It's an extreme environment. It's very different. So one thing that's going to happen in allostasis in a stressed situation, here's an important word for you, chatecholamines. That's a broad category. The most important ones in this category for you are epinephrine and norepinephrine. One way that your body is going to respond to stress is with stress hormones, the catecholamines. You may remember norepinephrine and epinephrine from such starring roles as your autonomic nervous system, fight or flight, right? You may remember them as hormones from your adrenal cortex, or sorry, adrenal medulla. I said that wrong. Norepinephrine can also be a neurotransmitter. Your brain also releases norepinephrine. So it's going to do all of these fight or flight things. It's going to change your blood pressure. It's going to change your respiratory rate, your cardiovascular rate, your cardiac output, your heart rate. It's going to decrease GI motility, so you're going to have less gastrointestinal motility. And it's actually going to inhibit your insulin secretion. It's going to alter your glucose metabolism. So in the long term, if you're stressed out for a very long time, that's going to have a massive impact on the way that your body functions. You have some other hormones related to the stress response. That adrenal cortex is releasing cortisol and aldosterone. Do you guys remember what cortisol does? What's cortisol do? It's not enough to nod, you gotta tell me. It's anti-inflammatory and what? Yeah, long-term stress response. So anti-inflammatory role, yes. It's synergistic and antagonistic. That means it can do both for catecholamines. It can increase it or decrease their efficacy depending. And anti-inflammatory sounds great at first until, a month later you start to get sick because you're not sending enough white blood cells around to things. What does aldosterone do? What's it act on? Blood pressure? How? What about urination? What does it increase? What does it decrease? There's lots of fingers going up and down, which is good. You're in the right place mentally. Higher blood volume. Yeah, higher blood volume, higher blood pressure, excellent connection. So aldosterone specifically acts on the distal convoluted tubule of the nephron to cause sodium retention and potassium excretion. We'll cover that again during endocrine week. That distinction with sodium and potassium by the time we get to the urinary system is going to be really important to you. You're going to care about those electrolytes a lot very soon. I think Karen Riley spends about 4 weeks on fluid balance, and it's all about where the electrolytes are. I'm like petting this like a cat. It's very weird. Okay, I should stop. All right. Endorphins. I want to tell you guys a fun fact here. I think it's really cool how this worked out. If you break down this word endorphin, endo and orphan, we discovered morphine before we discovered endorphins. We named endorphins endogenous morphine, the morphine our body produces. Cool, right? I think that's weird. So endorphins are our body's own chemicals that suppress pain. So you may need to be releasing endorphins during an extended stress response. Enkephalin is a similar substance. I think it's more recently discovered. It's more pain suppression pathway. I think that's all I got there. Sex steroid hormones like estrogen and testosterone will have an impact on the stress response, as will growth hormone, prolactin, and oxytocin. And obviously those things have a biological sex basis, so those can tend to be statistically different in biologically male people versus biologically female people, and that may contribute to our gendered stress response. There's a saying, and I can never quite remember what the whole saying is. Women tend and befriend during stress responses. I can't remember the male version, but it's basically like self-medicating and isolating, I think might be the rhyme. It's taking a lot of drugs and smoking a lot of cigarettes and drinking a lot of alcohol and being alone is how men deal with stress. Whereas women will like probably eat a lot of food, but also seek social content. It's kind of a stereotype, and I don't always agree with the gender stereotypes, but we are talking about the biology of how these different hormone levels will impact the stress response. This word over here, cytokines, during our inflammation lecture is going to be very important. You may remember cytokines. Do you guys remember cytokines? Cytokines. So it's a cytokine is a chemical signal. You saw it during our immunology lecture when we did our little play act for what the different white blood cells do during an immune response. Something, does anybody remember which cell released cytokines? Yeah, T helper cells. You get a high five. Good job. T helper cells, they release cytokines, and that is going to invite all of the other white blood cells to the party. Now we're going to broaden that a little bit. It's not just T helper cells that release cytokines. You're going to see some variations on this word, like chemokines, for example. It's just chemical signals that are chemically attractive to immunological cells. They're going to invite white blood cells to the party so that they can clean up, so that they can destroy invaders, so that it's going to be inflammatory. So you may have more cytokine release during a stress response, and that means you may actually have more inflammation during a stress response. Okay, all of this adds up. When we take allostasis and our sort of chemical state of the stress response, we're going to fit it into this idea of general adaptation syndrome. Honestly, I don't think there's much of a difference between allostasis and general adaptation syndrome. All we're saying here is the body is stressed. Your body does things in response to stress. It releases a bunch of weird chemicals, right? Your body's going to work really, really hard to overcome the stressor. And in working really, really hard, this is the stage where you're working really, really hard. Eventually, you deplete your body's resources. This is where GAS extends this idea of allostasis into its final moments. In GAS, there's an exhaustion phase. You've worked so hard to overcome your stressor that you've exhausted your body's resources, and that can lead to death. It could be something you recover from. Our goal is to avoid death, right? But we may not be able to overcome it. Exhaustion, energy stores completely depleted, unable to return to homeostasis at that point. Possible death of the organism is what we're trying to avoid with all of our disease states. So it's just a broad sort of functional understanding of what your body's doing in response to a disease state. It's responding to it. First it can't, then it tries, then it exhausts itself potentially. Which is why we like treatment, right? We can prevent the body from doing all these compensating. So if you're in emergency medicine, maybe you've heard the term decompensating. Somebody was compensating and then suddenly they're not, right? So that's what I recommend you tie into this idea of the GAS. It's just still definitions. It's just a framework of understanding. Yeah.
And at that point of going down.
Yeah, that point where they start to exhaust themselves, that would be what I would call decompensation. That's something I sort of brought into the fold later. I didn't originally lecture it that way, but then I learned about decompensation in emergency medicine, and I was like, that sounds like the final phase of GAS. So I just brought it in. Okay. So GAS, you could also call it allosteric overload. The wear and tear effect of adaptation is just too much. Same thing, really. I'm not going to read the slide to you. It's just a bunch of systemic effects of allosteric overload when your body's compensating and really is having a really hard time compensating, that's what it's going to look like. And that's about it. Let's see, adaptation means, so adaptation happens in an individual. If there is a change in the environment that we have to respond to it, successfully responding to it would be an adaptation. Coping tends to be the behavioral response to change. Some people will use adaptation and coping interchangeably, but I argue adaptation is a little bit more physiological, coping's more behavioral. And the stress is the inability to cope with the stressor. And I think that's where I want to start, or where I want to start. I'm going ahead and stop this now.